Okay, let's talk about brain tumors. We'll start with some symptoms that can tip you off that a patient might have a brain tumor. About half of patients with brain tumors present with headaches. The headaches are usually constant, non-throbbing, and dull. The headaches may wake patients from sleep. Brain tumors also can cause nausea and vomiting, which is seen more commonly in infratentorial tumors, such as in the cerebellum. Seizures can be a presenting symptom, particularly in supratentorial tumors that can affect the cortex. Brain tumors can also produce a number of focal deficits, depending on where they occur. There's a lot of different brain tumors, so it can be a bit overwhelming to study them. Let's think about the important features you should pay attention to in order to differentiate the tumors. A really important feature to consider is the age range you see affected by a type of tumor. You can divide brain tumor types into two categories: tumors generally affecting children and tumors generally affecting adults. Next, you want to have a sense of the World Health Organization grade. Brain tumors rarely metastasize. Instead, high-grade tumors cause death and are called malignant based upon their propensity to grow, invade, and interrupt critical neural functions. Tumors are graded on the WHO scale from 1 to 4 based on prognosis, with grade 1 tumors being benign and often surgically curable, and grade 4 tumors having a high mortality rate with poor prognosis. You'll also want to pay attention to locations where specific tumors are more likely to occur, such as in the posterior fossa or in the suprasellar region. And of course, you'll want to know the imaging and histopathologic characteristics of the different tumors. We'll first go over the tumors that more commonly occur in children. We'll talk about pilocytic astrocytomas, ependymomas, medulloblastomas, gangliogliomas, craniopharyngiomas, and germ cell tumors. Pilocytic astrocytomas are the most common brain tumor in childhood. They are a grade 1 glioma, are slow-growing, and have an excellent prognosis. They can commonly be surgically resected. Pilocytic astrocytomas most commonly occur infratentorially in the cerebellum. However, they can also occur in the hypothalamus. In neurofibromatosis type 1, pilocytic astrocytomas can occur in the optic pathway, such as the optic nerve, chiasm, and optic tracts. Remember, neurofibromatosis type 1 also presents with bluish nodules on the iris, bumps on the skin called neurofibromas, and hyperpigmented skin spots called café au lait spots. On imaging, pilocytic astrocytomas appear as a sharply demarcated cyst, generally in the cerebellum. They have a mural nodule on the side of the cyst that enhances with CT iodinated contrast or MRI gadolinium contrast. The cells in pilocytic astrocytomas appear somewhat similar to astrocytes, even if it is not known what the true cell of origin is. Like astrocytes, they have bland oval nuclei. Pilocytic means hair-like and refers to these eosinophilic strands in the tumor. There are both dense portions of pilocytic astrocytomas and loose microcytic portions. Rosenthal fibers can be seen in the dense portion. Rosenthal fibers are characteristic eosinophilic corkscrew or rod-shaped inclusions. Eosinophilic granular bodies can be seen in the loose microcytic portions and are described as mulberry-appearing eosinophilic granular inclusions. Ependymomas are a grade 2 or 3 tumor with histologic appearance similar to ependymal cells. They generally occur in children and can be found in the fourth ventricle and the posterior fossa. However, they can sometimes occur in young adults, where they are more likely to occur in the spinal cord. Because they often occur in the fourth ventricle, they can cause an obstructive hydrocephalus. On imaging, they appear as a sharply demarcated tumor without infiltration. They are contrast-enhancing on CT or MRI. In ependymomas, histopathology will show vessels surrounded by an acellular zone that is then surrounded by cells that look like ependymal glial cells. These are called perivascular pseudorosettes. True rosettes also occur in ependymomas. They are characterized by a central lumen surrounded by tumor cell processes. They are considered to be true rosettes as they have a basement membrane. True rosettes are specific for ependymomas, but only occur in 5 to 10% of cases. On electron microscopy, ependymomas can show basal ciliary bodies found near the nucleus, but this is not seen on light microscopy. Medulloblastomas are the most common malignant brain tumor in children. They're an aggressive WHO grade 4 neuronal tumor. They're rapidly fatal without therapy, but 5-year survival can be 60 to 80% with surgery, multi-drug chemotherapy, and craniospinal radiation. Unfortunately, childhood cranial radiation can be harmful to cognitive development. They're commonly located in the posterior fossa. Like ependymomas, they can also obstruct the fourth ventricle or the cerebral aqueduct and cause hydrocephalus. Medulloblastomas exhibit CSF spread and seeding through the subarachnoid space. They can cause drop metastases, where masses form in the lumbosacral spinal cord due to gravity-based seeding. Imaging shows homogeneous enhancement. On histopathology, medulloblastomas show small, round, blue cells with little cytoplasm. You can also see Homer-Wright rosettes, which are those same basophilic tumor cells surrounding an eosinophilic central neuropil. Technically, Homer-Wright rosettes are another type of pseudorosette. Gangliomas are usually a WHO grade 1 neuronal tumor that occurs in children. They're commonly located in the cerebral hemispheres. Because of this, they can cause seizures that are sometimes refractory to anti-epileptic drugs, particularly when they're located in the temporal lobes. Imaging characteristics of gangliogliomas are similar to pilocytic astrocytomas. They appear cystic with a contrast-enhancing mural nodule. Gangliogliomas can often be treated by surgical resection when they're in a location that's amenable to resection. On histopathology, gangliogliomas show binucleate ganglion cells, numerous eosinophilic granular bodies, and perivascular lymphocytes. Craniopharyngiomas are a suprasellar tumor originating from Rathke's pouch. Remember from embryology, the Rathke's pouch is a precursor to the anterior pituitary. Craniopharyngiomas are most commonly seen in children, but they do have a bimodal age distribution and sometimes appear in older adults. On imaging, craniopharyngiomas are located in the suprasellar region above the pituitary and are calcified and cystic. Upon resection, the fluid contents are described as looking like motor oil. As with any tumor in the suprasellar or intrasellar region, craniopharyngiomas can cause compression of the optic chiasm or endocrine pituitary abnormalities. Here's an example of the adenomatous variant of craniopharyngiomas. We can see keratinizing squamous epithelium with basal palisading of nuclei. There are also areas of wet keratin with outlines of where keratinocytes used to be. We can also see stellate reticulum. The last type of brain tumor in children that we'll talk about are germ cell tumors. Germ cell tumors are neoplasms arising from germ cells that incorrectly migrated to the intracranial space instead of to the gonads during embryonal development. You may remember hearing about all the different types of germ cell tumors in the ovaries or testes. Like those germ cell tumors, there are a number of different subtypes of germ cell tumors. The germinoma subtype is the most common, but there are also mature and immature teratomas, choriocarcinomas, yolk sac tumors, and embryonal carcinomas. Germinomas tend to be very radiosensitive. Mature teratomas tend to be resectable. Choriocarcinomas, yolk sac tumors, and embryonal carcinomas carry a worse prognosis. When germ cell tumors occur intracranially, they tend to occur in one of two places, in the pineal gland or in the suprasellar region. Regardless of their location, germ cell tumors can cause precocious puberty. Germ cell tumors are equally common in the suprasellar region in boys and girls. When germ cell tumors are located in the pineal gland, they're referred to as pinealomas. Pinealomas are much more common in boys than in girls. When they're located in the pineal gland, germ cell tumors can compress the tectum and cause Pernaud's syndrome. Let's briefly review the anatomy of the pineal gland. The pineal gland is located here. You'll notice that's right next to the dorsum of the midbrain. The tectum of the midbrain is located here, dorsal to the cerebral aqueduct. The vertical gaze center runs through the midbrain tectum, so vertical gaze can be impaired from mass effect from pinealomas, particularly impairing upgaze or looking up. You can also see pupil dilation and lack of pupil reaction to light in Pernaud's syndrome because of injury to the pretectal area in the midbrain tectum. With enough compression, pinealomas can also cause obstructive hydrocephalus from compression of the cerebral aqueduct. Here's an example of a large germ cell tumor occurring in a child. You can also see expansion of the lateral ventricles, signifying obstructive hydrocephalus. Here's a histopathologic example of the germinoma subtype of germ cell tumors. You can see large neoplastic cells with large nuclei and prominent nucleoli. Sometimes they will have vacuolated cytoplasm. These neoplastic cells cause a reactive infiltration of lymphocytes.